Hello and welcome to our presentation, NHS, we don't have a problem, how to go live with electronic prescribing in 6 months. I am Stefan Sikorsky and I am the delivery manager for Better. However, I was the project manager at Wye Valley NHS Foundation Trust from setup to implementation. I'm joined today with John Gwilliam, who is the lead ePMA digital pharmacist for the trust and the current project lead. John, over to you.
Thanks, Stefan, for that introduction. So yeah, just a bit more background about myself. So I qualified as a pharmacist in 2005. I've got 9 years of experience as an NHS hospital pharmacist, and I joined the Wye Valley Trust project team as the digital medicines pharmacist in December 2019. So a bit of background about Wye Valley Trust. It is a district general hospital trust in the NHS. There are approximately 400 beds in total, 250 of which are acute beds, and in addition to this, there are 3 community hospital wards in separate sites around the county. A bit of background to the project itself. The ePMA contract was signed with our suppliers in mid-2019, and we took delivery of the system in March of 2020. And the system was deployed with rollout beginning in October of 2020. By December, we had 8 wards live with ePMA across the general medical wards and paediatrics. And as we stand now in May of 2021, we have 18 wards live, including all 3 of our community hospitals. So we did face some challenges along the way as we were rolling out the system. So I'll go through some of those challenges now and what we did to overcome them. The first challenge that we should talk about relates to training. So obviously when you're rolling out an ePMA system, it's important that all the users of the system are trained to be able to use it and log into it in preparation for the go live in a particular area. And initially, pre-COVID at least, the drive and the desire was to do face-to-face training with staff, and that was done or planned to be done by way of appointments made with staff on the wards, and also with large classroom type teaching sessions to cover large amounts of users all at once. But we found that the COVID restrictions and challenges made this particularly difficult. There were a large amount of staff absences due to sickness and the need to self-isolate, and this put additional pressure on the staff that were working, meaning that any appointments that we did make, it was quite likely that we were unable to train that person if they were too busy. Also, when we were looking to do the classroom-related sessions, then social distancing requirements made that extremely difficult as well. Because we couldn't train as many people all together. So that did pose a particular problem to our rollout and could potentially have risked the planned go live dates that we had if we were unable to train enough staff in time for that. So what we did, we acted on the feedback from the staff themselves, and we moved our training to an online platform, which could be accessed from inside the trust and outside the trust as well, including by agency staff. And what that did was it allowed us to very quickly get through our training with the users of the system. And we managed to hit extremely rigorous training requirements in time for the planned rollout dates on the different wards. Another challenge that we faced, which I think is probably true of any ePMA project, was a feeling of resistance to ePMA. Obviously, it does represent a significant change in the way of working, and there is a perception of difficulty and a steep learning curve involved. So what we found, particularly in the later stages of the rollout, was an approach of rollout by consent, which really involved extremely intensive stakeholder engagement. And particularly important is the actual involvement of the stakeholders and the clinical managers in the preparations for taking their ward live. So in terms of the equipment, the delivery, making sure that the staff were trained, and that really did create an atmosphere of partnership and ownership between ourselves as the ePMA project team and the clinical staff in the area that we were preparing for go live. And that meant that there was more of a sense of ownership and a team atmosphere, rather than them feeling like the system was being imposed on them externally. And with that, we found that we were much better able to meet the challenges of rollout and overcoming the obstacles as a team. So in conclusion, intensive stakeholder involvement is extremely important in creating a team atmosphere and a sense of partnership around the preparations and the go live process itself. And what that means is there is a real atmosphere of cooperation and camaraderie around meeting the challenges that you'll always face when you're taking a system like this live, and in meeting any obstacles that could otherwise have derailed the implementation. So that concludes my presentation. So I'm now going to hand you back to Stefan to talk more about the project. Thank you.
So thank you, John. So let me introduce myself a little better. So I am Stefan Sikorski. I am a qualified nurse who maintains my own clinical registration, and I qualified in 2006. Where I was working, I was actually on a ward that piloted electronic prescribing medicines administration. And it was at that moment I realised the potential and power of relevant clinical information at my fingertips. There was no more searching for charts, there was no more rewrites, illegibility, and I was hooked instantly on the benefits of ePMA and EPR solutions in general. Recognising my enthusiasm, the lead pharmacist for the project brought me on into work into pharmacy, and I assisted the implementation of ePMA across all 3 hospital sites in a year. Following on from this, my ePMA and ePMA passion has led me to take on a number of roles in a number of trusts, and to date I have implemented 5 different ePMA systems in 6 NHS trusts. I've also benefited as a clinician being able to use all of these different systems and find out how they work for the nurses and the doctors in their environment, as well as actually using more than the ones that I have implemented. So I've got experience from different systems. 11 years later, and I joined Y Valley in January 2019, pre-procurement at the very start of the business case. And it was then that I knew the target and the deadline. And so I used my key success factors to ensure that we had met that deadline, which is what we'll talk about today. So my success factors for a speedy rollout. Stakeholder management. It sounds relatively simple. We all understand the power of influencers and understanding how to get the staff, but let me take you back to a time when I once joined a trust in the Midlands, and I joined so a week before they went live in theatres. The trust, through a lack of engagement with the anaesthetist and a lack of stakeholder management during the build, within 2 weeks of it going live, the anaesthetists there had a massive complaint about the system, and we had to have it removed from theatres, which is very disappointing for any project implementation team. So I got to understand what it is they were after, and we had to work very hard and close with the anaesthetists. Had I had the understanding beforehand, we might have saved that rollout, but anaesthetists, like all of your staff in all of your trust, are key. Anaesthetists themselves, they are the largest consultant body in any given trust. Things that I learned at this implementation. They work across multiple specialities, trauma and orthopedic, obs and gynae, pediatrics, you name it, whatever your hospital is working on. Your anaesthetist may work amongst all those specialities, working with the surgeons. With the largest voice in the trust, they may have some of the greatest influence. If an anaesthetist, for example, tells your surgeon that the system that they've got is cumbersome, then your project is already getting tarnished and having a bad name at the start of the programme. by finding the most influential and the most vocal, and also, dare I say, quite difficult member of the anaesthetist. We worked with him in the trust to build order sets, and the pharmacy team and the pharmacy leads there, we all worked quite close. We developed a new teaching package for them. We managed to get a new support package in place for them, and we built several order sets, everything that made the system that they had to use eventually the best possible system it could be. At that point, we then went live, and they told their surgeons were quite happy, and it made the rest of the project a lot smoother than it would have done just by having that one core group. So that's your influences. It could be that that influencer is like John mentioned in his presentation, it could be one of the consultants. John worked with a lot of the consultants when we were talking about Y Valley to build order sets, to build the system for them. And it just made the transition into their area a lot better. It goes without saying that at your board level, this is your governance. You need to have the sign off at board level for your key project decisions. Now, prior to myself starting at Y Valley, the project board at Y Valley had already been created, and this was a mixture of probably one of the best project boards I'd ever worked with. We had the clinical director of pharmacy, we had the financial director, so any kind of value passing through was ratified. We had the medical director, so any problems within the medical divisions, the surgical divisions, we could always go back to ask the medical director for. And we also had the nursing director initially until she retired, but we managed to find somebody else to replace her. So anybody that was at executive level that could make a decision for the project, for the benefits of the rollout, they were all there. And they were also able that even if we couldn't come to a decision at board level, they were the people that could take it to the higher levels, to the executive board levels. So it is very crucial to not just understand the users, but who can be your project board, and they are your successors. Another factor that I take with me everywhere is having clear targets and the determination to meet those targets as a minimum. Don't over-engineer your targets. There are so many hospitals that will put too many values into their OBS, your output-based specification. This is the document that you will design with your trust that asks you, what does your trust want? Do you need a system that will integrate with your pathology system? Do you need a system that will integrate with your PAS system? This is what your OBS does. Can you prescribe? Can you do variable rate infusions? I am fortunate to use many of these systems and implement many of the electronic prescribing systems out there, and they do all have their weaknesses. No one is perfect. It could be that you've got one of the greatest, biggest solutions that is dominating the UK market, but they are unable to support variable rate infusions. They might not be able to do pediatrics as well as you want it. It could be a solution that has slick advertising behind it. However, it may only work on an iPad, and you will know that nurses need keyboards, doctors need keyboards because of the litigation society, litigation nation we are in. People need to write down their answers to why they have or why they haven't done something. However it is, whatever your targets are, I always start from the basics, the bare bones. The e-prescribing toolkit website had the 2007 Connecting for Health OBS for what an ePMA system should have. Now, this may be an old dated document, but it still offers you a glimpse at what the minimum should be. Know your minimum target. My minimum target is if it matches paper or better than paper, then that's what you're going for at point one, at phase one. So manage those expectations and be realistic. I did not, we at Y Valley did not go live with having VTE, for example, blocking prescribing or having any intelligence behind the prescribing. We didn't have a full integration to laboratory systems, because these are brilliant, but at the moment your paper chart does not have that either. Your paper chart has your patient's name, has their clinical details, has their allergies, and has the medication prescribed, and it's with the bed that they're in. So that's what the minimum we wanted, or I wanted, and signed off at board. So this was an integration to PAS, so we knew who the patient was. This was a simple allergy system. Whether that was integrated into EPR or not did not matter. It just needed to work in the solution, as well as height and weight for some clinical decision support. By having clinical decision support by a structured DM&D, the background was already much better than the original piece of paper. Going back to your business case, you may have a line in there for your cash releasing and non-cash releasing benefits. So understand what it is that you need to prove that it's worked. The cash releasing benefit that a lot of the trusts go for is the reduction of drug expenditure. This can vary from 3% to 14.5%, but there's many different studies out there. A lot of trusts aim for about 6 to 7, which is your benefit from having the structured DM&D. So don't aim too high. You may have meetings with your stakeholders that will ask you questions such as, my product, will it stop me from prescribing 2,000 milligrams of aspirin? My answer to a person that ever asks me that is no, you will stop yourself from prescribing 2,000 milligrams of aspirin. That's what you've learned to do. Don't forget, this is the system to not replace your thinking, but to assist your working. So I've created a checklist of targets that was used to help manage expectations. And this was, what does a simple ePMA solution offer? What does a more complicated ePMA solution offer? And what is the ideology of an ePMA system? And sold the basic. This is what we went live with. The next point I'd like to talk about is collaboration with other trusts and site visits. It may be that you are collaborating with a GDE in another site. It may be that you are using your forums, such as your pharmacy groups, your antimicrobial groups. You talk to staff from across the country all the time. Ask them what their solutions are like. It doesn't have to be the one that you're looking at implementing, but it can be a solution that has problems with it that you are discussing. How does it affect the pharmacy department? How does it affect the nursing department? How does it affect the physicians? See if anybody has got a rollout and take part in another trust rollout. We were fortunate to be following Taunton with the electronic prescribing at Wye Valley, and we made very, very close network connections with them. John still keeps in touch with everybody at Taunton. We're keeping in touch with those in Plymouth. So now there is a nice collaboration of a group that's growing by the day, where problems can be solved and shared. The team that I was working with hadn't actually been part of a rollout before. And so when the opportunity was presented to go down to Taunton and help them, and I want to say help loosely, to help them do a day one go live, we, both myself and John, suggested it would be a great ideology for the team to go down there to see what it's like, to see how busy it is, to see the problems that might arise. You know, maybe we got in the way, maybe we asked too many questions. I don't see us being helped, it helped us, and it may have helped Taunton as well. I need to go back and ask him that question. Either way, it was a good benefit. Join the community. There may be, depending on the supplier you're working with, they may have a community. I know better there is the Meds Club, and this is an example of the Meds Club. And monthly, each of the each of the trusts that have the better solution or will get together, not to talk about the system, but to talk about their implementation, their problems, the things that are the sticking blocks for them, how they overcome them, everything that's outside of the system, but inside of their own trusts. And it's a great way of meeting new people and designing ideas. This one was actually the last one, and that was all about that was actually talking about implementations, as it were. It's very helpful. Now, the next section is getting buy-in with the trust, and this is talking to your key users, the people that you will talk to the most, people that will be using the system the most. Here is a photo of us working at Y Valley, and you'll notice that we are wearing bright blue ePMA t-shirts. We had designed these with our implementer ePro, who had kindly bought these for the team so that we were very visible on the onset. And I give an example of such. Once we were working overnight and it was 1 a.m. Doing some transcribing and support on the trust, and as I was walking down the corridor, I heard the pitter-patter of a nurse running up behind me and grabbing me on the shoulder, asking me for some help, because she had identified from quite a distance that we were there to help. But be visible means organise events, be available, do not rely on email. Your clinical staff may not be looking at the intranet, they may not be looking at their emails as much as we want them to, and we would love them to. They don't have the time to, and they're sat doing their clinical work. So knock on doors, set up, for example, platforms in the canteen, ask them questions, get them engaged, get your names. And you'll see this picture here. We've got Mythbusters. What do you know about electronic prescribing already? How do you what do you expect from electronic prescribing system? And this was before we'd actually procured the software and signed a contract. This was going back right to the very start and the heart of the project. And you may notice that we had some incentives. So chocolates, black pens, green pens, anything that can incentivize engagement. So bringing people to you and keeping them with you. One such example from Y Valley is that in talking to the team, we recognized that when it came to training, we may have an issue getting people out of the clinical area. One of the other projects had opted to offer the nursing staff time, and we recognized that the problem with offering people time back is that, especially clinically, you very rarely get that time back. And so we came up with an idea to incentivize the actual engagement itself. And so we went to the RCN, and we had the nurse training accredited for continued professional development. So now every time a nurse is trained on electronic prescribing face-to-face or via Teams at Y Valley, they have this for their revalidation, which they use every 3 years. The final point is be available and listen. So once you've got the product, this could be as soon as you've got an environment, make sure that you go out and talk to people, hold events, not just like in the canteen, but show them demonstrations, take the product to them, get them involved in testing, buy loads of laptops and listen to their issues. We did have, as John quite rightly mentioned, we had some problems in the first part of the medical rollout where through speed or through lack of awareness, towards the latter end of the ward, we weren't available and listening as much as we could have been. And we did have issues in the final area where there was a miscommunication, and we learned from that, and we made sure that going forward we would be more available, we would listen more, we would do everything we could to knock on doors, to go around the hospital, to get people involved in working groups, and really make sure that people signed off their rollout before we rolled out. Prior to medicine, the rollout was we created a checklist of what we needed to go live. So the go live checklist was: have you got enough staff in your area trained? Yes. Have you got enough support on go live? Yes. Have you got your laptops ready? All a kind of checklist of what we thought was perfect for the area, and internally we would review that. The push from what we learned in medicine is we would review that, not internally, but we took that to the key stakeholders, so the senior consultants and nurses and matrons in that area, and said, this is what we've got to get your area ready. Do you agree in that? And then they would sign it off alongside us. Another point I'd like to talk about is team management. Now, you can good team management isn't just about finding the ideologies of telling people what they need to do. As you say here, if you want to build a ship, don't drum people together to collect the wood and assign them tasks, but teach them that the mission is the same mission for all of us. We want to get to go live. We want to be successful, and that's what we need. We want to build the same ideology with the whole team. You can learn from the past. You can save yourself some time and look at other people's business cases, look at people's structures, and you can already get an idea of what the perfect structure is. Having a good lead pharmacist, for example, is really helpful. Having a great pharmacy technician that knows the product, a nurse that knows clinically, having these key staff really is good structure, and that's built in a lot of OBA in a lot of business cases, and you will pick that up from them. You can then look at other structures and decide, do you need to tail back or have more? Because they're always there. You've got people that have testing teams, training teams, teams that you might be able to draw upon in your own environment. And then once you've got your structure, learn about their powers, learn about how you get the best out of the staff, and how to and what they can offer. And I'll take you back to Y Valley. When we went out to recruit a pharmacy technician, we had very good competition. The pharmacy technicians, very high caliber. They all had brilliant skills, a good varied background, and none of them had actually used ePMA before, so there was nobody that had a real strong footing in that area, apart from one of them who shone, and quite a few things stuck out. And these were things like he'd learned how to, well, he'd already been training and managing consultants. Now, that is not a very easy thing to do, to take consultants and teach them something. So having that as a skill is very fundamental to the team. So being able to go out there and talk to people that might be critical. He was also known the trust for a very long time. He'd been working there for some time, so he knew everything about Y Valley, from the good to the bad, the things that made it tick, and he was very good with the staff. Now, for example, you could send a pharmacy technician out. He could go on a walkabout for 2 hours, 3 hours. Didn't always know exactly where he was, and you didn't need to know where he was, because what you did know is that wherever he was, with whoever he was talking to, he was advocating the ePMA system, advertising it, and drumming up that support, whether it is in pharmacy, on a ward. And you'd only have to walk around with him for 10 minutes to notice that, because people would run up to him and say, hey, tell us about this, and tell us about it. It was very, very powerful, just by having someone that was really outgoing. Leading by example. So this is one thing that I'm hoping the team will have noticed, in that I was very determined to get the project going, to make the project successful, and I was hoping that would knock on effect to the people that I was working around. And often, as much as I would moan about it, I would be doing 60-hour, 70-hour weeks sometimes to really get that project going. And I'm hoping that that was echoed amongst the team, so that it gave them the kind of buy-in that, well, he's not just sitting there, sitting back, he's actually proactively carrying on, and we're all working together. We're not just a segregated group of staff doing our segregated things, we work off each other. Things we also did was, it wasn't just one person's decision. So whenever there was a problem that needed a resolution, we would all get together and we would have regular catch-ups and meetings to say, well, this is the problem. How do you want to solve it? How shall we solve it? Let's all solve this together. And then motivate and encourage. And this isn't just about motivating them to see the end of the ePMA. This could be motivating and encouragement by other aspects of their role that they want to get out of it. So we've got there was a nurse that wanted to have a lot more experience at a senior level, more management, more involvement, and so we proactively gave her the encouragement to go and do that, to sit on certain boards inside and outside of the project, to write policies, to actually contact the RCN to start the negotiations, and to basically lead the whole project for getting the training accredited. So that was all down to this one person. That's what they wanted to do. So by giving them that encouragement, that little bit of motivation, really makes people happy in what they're doing. And you can't always, sometimes we forget that people have their own goals that are outside of the project, but let's make sure the goals are aligned and we can keep them together. The last thing that I would like to talk about is implementation plans, or the ability to not have too many implementation plans. So talk about your backup implementation plans, not just the best case, but how you can get it live. Now, one thing that John and the team will know is I don't do the D word, and the D word in this situation is delay, and I am not a big fan of delays. And I decided that we would do everything possible to make sure that there was no such thing as a delay. Some of the things that we did to make this is to start with the first two plans, and this was right back at the very beginning. What is the worst case scenario and what is the best case? The worst case scenario is we had to get everything finalized over the line by March 2021. This was having a percentage of beds on electronic prescribing, and that's exactly what the worst case scenario did. How late can we start? And we looked at the timing, and we could start around about mid-January to early February and get that percentage of beds in. And that's what, if everything went wrong, that's when we could go live and still meet the target. The best case scenario was meeting the milestones, which was by going live with a pilot in November. We actually aimed for October, but going live with a pilot that quite early on, and then keeping the areas together, doing it a little bit more slowly, having some more time to reflect and make sure we get more than the basic amount of beds. So the worst case scenario was 50% of beds. Best case scenario was about 90% of beds, 87 to 90. By having the plans in place, we were able to come up with solutions to problems. So plan 2 came when we realized that there was a hospital change. This was a new building that was going to happen during our planned rollout, either in December, perhaps January, maybe February. We weren't given a definite date because at the time of COVID, they couldn't give us the exact date. So by knowing our ward specifications, our wards and themselves and how they work together, we planned to have a gap. This was keeping our pilots together, this was keeping medicine together, this was keeping surgical together, community, and so on and so forth, knowing that if it was coming in December, we could drop the one and then move it to somewhere else in our plan and still meet the target. Another problem, we had a second wave of COVID. Now, the first wave hit us just at the time when we'd managed to get the solution, so it didn't really affect rollout, but the second wave and indeed the third wave did have an impact, or a potential impact. By negating the risk, we had extra risk assessments. We had the team all had their quick tests for COVID, the rapid COVID tests on a twice weekly basis. Everyone was fit mask tested in case we had to go into the site. And we also moved a lot of things onto online learning, onto non-face-to-face, and worked outside of the office. Didn't actually affect the rollout plan, but by keeping the continual eye on what was going on, we knew that which wards were going to open, which wards were going to close. And as it happened on the first day of go live, one ward, our pilot ward, had merged into the ward next door, and we ended up with 50% extra beds to manage as a capacity. But by continually looking at what was going on, we were aware and planned for that. Our other problem was that we had more than one IT project going off at the same time. And we were asked to, and we noticed that that one of the projects would have gone live at the same time, on the same day, in the same area, and this would have a negative impact. We're pushing too much onto the nurses. So always be aware of what else is going on the wards. And we couldn't have a nurse being taken off for an hour of training in the one project and then an hour off for ePMA. And it was just too much time and too much pressure. So we agreed as a team to delay our rollout by a number of weeks. It was actually 2 weeks. And the only reason why we also were allowed to use the word delay in this instance is that we, instead of actually preventing the project from going forward, we took down our pilots that were originally 3 weeks down to 2 weeks each, which gave us our time back. So we didn't actually have any impact, but we optimized the plan, kept our targets. There was our biggest problem, which were the patients coming to paper wards. Now, I mentioned in our first plan we wanted to go live with AMU. The reason why we didn't go live with AMU is because COVID wave 1 came on board, and we didn't manage to get the stakeholder engagement in the emergency department in order to ask them if we could go live there first. So we did a SWOT analysis, we took it to project board, we said we'll go to medicine first and then leave AMU to the very end of the project, and come back to it once everything's settled. As it happened, our fears did arise, and we did have patients coming in via ED, via AMU, going to the wards on paper charts. The on-call staff of a weekend, of an evening, hadn't had their training or wouldn't do their training purely because it was that they're only doing one shift. And so there was a build-up of paper charts. We even at one point had to go to project board, and John requested that we helped transcribe some of the patients that were coming through, because the risk was getting quite high that there was a lot of, that some of the wards could revert back to paper. And some of the things we had to do to negate the situation was we did hire additional workforce to help digitize. Obviously this is a costly exercise and it couldn't continue, but every Saturday we had an additional junior doctor who would support the wards by transcribing paper charts that were there, and then would support the on-call staff to get trained, to motivate them to understand how good ePMA is, because they liked it. As a junior doctor, they found it quite easy. and to really assist ePMA, as it were. However, as this is not sustainable, we called an emergency meeting with the medical director, the acute medical team, and the emergency department team to request that we went live with electronic prescribing in AMU and ED. How this affected the plan was we requested to move everything back by a couple of months, knowing our worst case scenario, plan 1, we could still meet the target, but pull AMU in January, which time-wise isn't brilliant because COVID wave 3 hit, the hospital was at its most busiest, but on doing the risk assessment to allowing patients to keep continually coming in on paper versus a high period of support for ED in January, the project board and the teams themselves agreed that going to ED was best. As it happens, we offered them 4 weeks of intensive support. The area themselves requested 2 because they thought they could do it in 2, knowing the system and having learned it. But by the end of week 1, they were solved and they were fine. And there was just a few technical issues rather than actual process issues with patients coming through to ED. So that was our plan. In conclusion, to what we were saying, and I'd like to go back to something that John mentioned. So as John mentioned, we are now 18 wards live, and this wouldn't have never have happened if we ever got discouraged by the challenges that came our way. As long as you're well prepared for your rollout, you know that if you've got clinical staff, we all work in clinical environments and unexpected events do happen. So when they arrive, don't just put blockers up. Don't see that as a way to, as a wall, as a potential showstopper, as it were, but use your team and use your skills that you've learned from going to site visits, from having your clear targets, from having your stakeholder management, and from having a good team structure to basically look for a workaround, get motivated by the initial timeline. And if it does require more work, then the satisfaction is so much higher when you hit the targets. And finally, I'd just like to leave you one final thought, and that is, I don't do the D word. I'd like to thank you very much for listening. I've been Stefan, and you had John. Thank you.